And now we will return to Mladen to answer the questions you have put in the Q&A tab. Mladen, the floor is yours, please.
So a big thank you to all the presenters. Again, very useful insights, visionary. I think the connectivity challenges we had in the presentation from the last presentation is a timely reminder of the systemic challenges that we face in scaling up digital health interventions in many countries. To use my own country, South Africa, as an example, these challenges include poor connectivity in rural areas, high data costs, low levels of smartphone access and use, and the very real problem that people often share one cell phone, the same cell phone. But we take comfort and note of other countries such as India, where there has been political will, there's been political support, and resources have been made available. So in the same way that clinical engineering practitioners were the thought leaders in the pandemic response, early on in the pandemic response last March. So in the same way that the clinical engineering practitioners were thought leaders and solution leaders, in fact, in some of the interventions that were required, for example, around non-invasive respiratory support, I think the hope is that in this space too, that clinical engineering practitioners in particular could become the thought and the solution leaders. And some of you are in this call and were on the call yesterday. There's a question from Riyad which relates to what I've just said. And Riyad posed a question in terms of challenges to entrepreneurs in low and middle income countries working on innovative digital solutions, knowing the absence of regulatory agencies and support in the countries. Would any of the colleagues on the panel wish to take that up, or Riyad, would you like to expand?
Well, first I will wait for the if any of the panelists would like to answer or give their experience on that regards. Any of the panelists would like to?
Okay.
Yes, Cindy, go ahead.
You have the floor.
Okay. So I would like just to say regarding a little experience that I had with like software as medical devices with telecardiology monitoring system. And like we have like the FDA and 510K, there is specific regulation when we can have like follow the different laws in order to regulate the software and the algorithm behind it. So, and I shared the link on the panel. So if there's anyone interested in order to follow. So in the beginning, it was very shy to see like AI algorithm and software as medical devices regulated by the FDA. But like starting 2019, we have numbers of software and AI regulated. So just I shared the link on the forum and will be more than happy to discuss also with you. Thank you.
Mladen, if I may add a little bit, that really low and middle income countries, they struggle a lot. We have lots of brains, but unfortunately we don't have the organization. So entrepreneurs have to struggle to find their ways in. We don't have the regulatory bodies to assist. We don't have straight rules for testing and for validating and then for marketing. But at the same time, there is a big need just like any other country, and especially after COVID. So I wish that through those webinars, we were sharing more information to everybody and hoping with time, our countries would have maybe a focus or a vision or a strategy regarding AIs and digital health just to aim at. Thank you very much.
Thank you, Riyad. In yesterday's webinar, the notion of leapfrogging was mentioned a few times. And if I could ask Professor Mark Nyssen, who's been involved in some very exciting digital health innovation in Africa, as you've heard, for his take on it, because Mark has worked in environments where, in fact, governments, and I assume the regulatory agencies have been very supportive. Mark? Mark, are you hearing me? It seems that there's a virtual Mark in the room. The real Mark has left. I'll put that question to the real Mark when he returns. So would anybody else like to comment on what Riyad has mentioned? I know, again, yesterday there were great examples from the Americas region, Pajo region, of great work that is being done there. And again, there's obviously great support there. And again, I'll come back to my opening remarks. Is this a case where we can actually, as a global clinic engineering practitioner community, put forward the value proposition to our various governments using experiences in countries such as those in the Americas and in India? I see that Rosanna would like to comment. Rosanna?
You're on mute somehow, Rosanna.
Rosanna, we don't hear you.
Better now?
Yeah.
Better?
Yes.
Okay, thank you very much. The presentations were amazing, Laden, as well as you and Pedro as moderators. I found very interesting each of the presentations. I just would like to share with Riot and Saida, excuse me, also with
We're not hearing you, Rosanna.
my question posed send to Mark Nissen, if we can observe some kind of opportunity we have to improve this this synergy. This dynamic, which is positive, but I felt this still isolated in some way, disruptive. I am a believer that this could be better if we can find a way to make such a type of synergy between us. Thank you.
Mladen, I don't have the direct answer, but I know my colleague, Dr. Sharma, has wrestled with these issues, particularly the last year, and maybe after him, Mark could speak. Jatinder?
Maybe I'll let Mark speak first.
I'm sorry, I missed a lot of your conversation without not having sound. There was a big interruption of your sound. What's the question?
Mark, I'll come back to you. Perhaps, Jatinder, you could actually carry on and respond to Rosanna, and then I'll go to Mark. Thank you.
Well, Jatinder, and it's the question of, are governments starting to tie digital health initiatives together? Are they starting, whether it's the clinical engineering community or wider, and how can we make a difference? I think you've done that a lot in India the last year.
I got the full question only now, so thanks, Tom. The thing is, the governments are more and more taking cognizance of the fact that digital engineering needs to be patched, if I can use the word, with clinical engineering. But the approach we have seen so far is a siloed approach, where governments tend to think that digital health and clinical engineering is for large healthcare institutions, 1,000 beds, 2,000 beds, hospitals with 20 operating rooms and 200 bed ICUs. Whereas the real democratization of digital health and clinical engineering needs to start bottom up. Perhaps it doesn't give as much as claps and ribbon cutting as doing something like this would bringing when you do it in large hospitals, billion-dollar projects. But I think the real stack of digital health and the repository that it would build for us to take guidance from it in future would happen only when we started bottom up. And therefore, so the short answer to that question is, yes, governments are taking cognizance, but at this moment, it is focused largely on large projects, large hospitals, and places where complex clinical work is happening. Organ transplantation, doctors talking to a specialist far away, and not in physician consultation, not in home-based tracking of risks in maternal and pregnancy care. It's not yet happening in those areas. And that's where I think we can converge to ensure that our collective wisdom and efforts can once again democratize it, take it to the people, and build the stack for the institutions rather than starting from the institutions, hoping to reach people someday.
And Jatendra, just as you say, taking it to the people, that's where it's going to make a real difference. And that will give the momentum to really drive it down to the people. So,
absolutely.
Yeah, I think, Jatendra, you just, affirmed with what I said earlier about clinical engineering practitioners and biomedical engineers being the drivers and the thought leaders and the solution leaders in this space. So thank you. Mark, if I can come back to you. So Riyad had asked the question around implementation of digital health interventions in countries where there is no regulatory support and, if you like, political will. And I said, yes, that is a reality in many countries, but also from your experience, you've also had some very positive experiences in terms of government that is supportive and political will that is present. So perhaps if you could put perhaps a more positive spin, but also indicate from your experience some of the successes that you've been able to achieve in some of the projects that you've been involved in.
Yes, first of all, I think there must be a convergence from the bottom up and the top down. Top down means that the government or the Ministry of Health takes central actions for the whole country. And this is very useful. You can have a database that covers the whole country regarding medical devices, and this is very good, because then you know what is the situation. Bottom up means that the people in the field get support. We saw this a big difference between Burundi and Rwanda for medical device management, for example. In both countries, they put up a central database covering the whole country, and which was successful. Now they know which devices they have in the country. Up to 95% of the installed base is covered. But in Burundi, they also supported the management of the daily work of the maintenance engineers, which led to very, very positive results. In Rwanda, they didn't do that. And now in fact, they put more burden on these people by not supporting their daily work, but they put the burden of putting in place the inventory every day. So that this is, I see you need convergence between the two levels. This is very important. There are things that cannot be done by the individual hospitals or the individual health workers. That must be taken care of by the government. For example, a unique patient ID. This is useful in every country, and this cannot be done by the individual. You see what I mean?
Yeah, thank you, Mike. I think what you say is true. I think the question would be: is it true for all environments and for all countries? So in smaller countries, it may be possible to implement the solution that you propose. In other countries, it may be more difficult, including my own. And then the question is, at what point in the healthcare system and the hierarchy do we enter? So I think that is a, if you like, a challenge for all of us in terms of developing workable and feasible scenarios in different settings.
In the case of very big countries, you will need a more distributed health system where the provinces or the departments are more have more freedom. Okay, and it would be interesting to find a reasonable size that can be managed centrally. Maybe 10, 11 million people can be managed by one entity. But when you go to 100 million, it's impossible.
Yeah, and I think that talks to your own presentation, Mark, where you spoke about the district health information system.
Right.
So if we take as our locus and our focus for implementation of district, I think it becomes
Yes.
much more manageable. And then it's a question
Absolutely.
of managing the interfaces going upwards and going downwards. Thank you.
Absolutely.
Other colleagues?
Okay, from Medellin, Colombia. Here we are trying to build innovation in healthcare ecosystem, try to work universities with hospital and with the politics. Okay, try to make the best way to achieve or to try to make the best results of our projects, because as you know, there are a lot of obstacles or tackles for make this innovation to put this innovation in the reality. So the idea is try to work together to make the best politics and make the best way to put this innovation to the reality, to the hospital. So that is the idea, and the universities are working with the hospital and with politics in this.
Javier, thank you. I've had the opportunity and the privilege to go to Colombia, and I know many others have, and I'm excited about how many universities are working together. I mean, universities in various cities and in the same city are connected with the health system, with the hospitals, Javier, but you guys are working together and collaborating in a unique way that's very helpful, a great model. Milad?
Oh, yes, yes. In this moment, there are a lot of 10 universities working together from different cities, from Medellin, from Bogota, from other cities. And the idea is try to develop these new politics together. So there are, in this moment, we are 10 universities working in this. And the idea is from Medellin. The origin of this idea is from 4 universities here in Medellin, but other cities are working with us in this moment.
Thank you. I think when you talk about collaboration, I think this also opens up the possibility of multi-sectoral collaboration, because if we're talking about digital health, then the tools of digital health are also applicable in other sectors. So why can't the same tools be used to address issues around water, sanitation, waste management, especially in LMIC? So I think that again is one of the leverage levers that we can actually play, particularly in a setting where we may not initially have political support, but if we can come up with a value proposition that is in fact multi-sectoral, so that it is a no-brainer to any government or authority, whether it's local or national, that this is the way to go. I think we can certainly have greater chance of making an impact.
Miladin, regarding references in the region that are working nicely in the interaction between the academia and the government, which is really the way we have to make, we are able to make sustainable initiatives in digital health. Chile certainly has made several efforts and also distinctive outputs. This synergy between the academia and the enterprise seems to be more dynamic in Chile, but of course our colleagues, partners from Chile can make this more visible. The support, if we just rely on the efforts and initiatives from the academia alone or from the enterprise alone, it won't, I believe it won't be as much as on time as we need in the region now. Let's invite our partners from Chile to share with us how this partnership between the enterprise and the government works in Chile.
Is that for Vesna or Maria?
Okay, thank you. Thank you for the question. It's hard to in this moment because the relationship in the enterprise and the government mostly is about the politics is complex, but in this case, in hospital digital, and we buy the service in the enterprise, and that's all. It's the relationship is more in the academics, more in than enterprise.
Thank you for that response. I see that there have been two more questions posed. The one was about the need for telemedicine and artificial intelligence in healthcare. And I see that Riyadh is typing an answer. And then there's just a flag from Caridad Boras to say, talking about collaboration, don't forget the medical physicists. They are also involved in digital health. So yeah, again, we're talking about multi-sectoral, but it also should be multi-professional. And medical physicists and hospital engineers and hospital architects are very important partners in our journey forward, because collectively we need to fashion solutions that will be feasible and address the needs of society as a whole. There's also a question from Nelson Escobar, I guess a difficult question to answer. So in the panel's opinion, what was the best lesson learned from the COVID-19 experience? I think the best way to answer that would be if in this year's Global Clinical Engineering Day in October, that in fact a session is set aside for the best lessons learned from COVID. And I think that was done in last year's Global Clinical Engineering Day, if I remember correctly, Tom, and the same, will be done again. So in the next, say, 5 minutes or so, we should look at wrapping up. Would there any of the panelists like to raise new issues or respond to issues that have been raised, or have any further thoughts?
Well, just a very quick thought. A year ago, when the WHO held the World Health Assembly virtually for the first time, on the lips of all the leaders, ministers of health, prime ministers, was ventilators. This year, they had to meet, the 194 member states of WHO met again virtually in May, a couple months ago now. And the word on all the lips of the leaders was oxygen systems. My point is, this is the time, the iron is hot. We need to strike now and connect academia, government around digital health and all the other stakeholders. Back to you.
Back to you, Tom. So what would your suggestion or thoughts be about exactly how we do that, and what would be the next steps at a very high level?
Once again, I'm good at talking about it, but somebody like Jitendra Sharma is doing it. I mean, the government has asked Jitendra and colleagues like HIMSS, the big health IT digital health leaders of the world, and CED to work on connecting, as Jitendra was talking, these digital health tools to the wider population. So Jitendra, I don't know if you have any insight. We haven't done it yet, but we need pilots like that where we demonstrate the power of digital health.
So thanks, Tom, for putting the ball in my court again.
Oh, yeah, brother.
Look, what I have seen is the academia and research institutions consume a lot of funds, and public representatives do not see actually those funds getting translated into anything tangible other than the degrees that are awarded in the universities. Now, this is the time when industry is under pressure to produce more and more healthcare technologies, and technology transfer from academia to industry is extremely relevant not just to ensure the knowledge resources that have been developed in academia to get passed on to industry and gradually to the patient, but also to prove their own value and existence to the public funders. Because technology transfer is an established stream of revenue that brings back something, whereas every university and academic institution is only seen as a cost center by the political representatives. So what we have tried to do is simply to pool technologies, platforms, intellectual properties on a non-exclusive basis from academic institutes, pooled and converged to us, and auctioning it to industry that wants to make the best use of it on non-exclusive basis. So we have 7 technologies from academic institutions on oxygen concentrators. We have 2 academic and research institutions working on alternative replacements to geolite, for example, which is used in oxygen concentrators. Now, when we do that, we are not just funneling industry and ensuring jobs to clinical engineers, both in the manufacturing units and in hospitals, a wider reach of technologies to patients and citizens, but also bringing back resources into the academia because of the technology transfer and proving to the public funders it is good to put money in science. And I think if there is one answer to what you asked, which is extremely relevant question, how to prove our worth, how to work together. For working together, we need an excuse. And in medical technology, the excuse is technology transfer. Over to you, Tom.
He nailed it, Milan.
I do agree. Jitender, just excuse me for the interruption, Miladen, but it's so true. Again, if we just rely all the initiatives from the academia or from the government, it won't work. And for that to happen, we need to get out of the box, and get out of the box is focus on the needs, as WHO and PAHO states always. Think about the population and who is in the center. In the center is the population that we don't want to be now infected by COVID, but before the COVID. We need to find a way to work better together, to make the synergy between Europe, Asia, or India and Latin America together. And for that, we need to think in other strategies like the ones Jitender is amazingly sharing with us by the side of the work we are doing with the virtual courses with Toby Clark among several countries. Each of these courses focus now in innovation, whether health technology management, health technology planning, and lately HTA to medical devices. But we are not working in the academia. We are working focused on mostly the governments, and then some groups of the governments, different governments, Peru, Colombia, Ecuador, etc. And those are synergies looking facts, not just contents, knowledge, but solutions and problems in the real context. Thank you.
Thank you, Rosanna. I think that's very valuable, very, very thought-provoking. I mean, one of the, again, touch points and interfaces could be to work through the WHO regional offices. Because Tom mentioned the World Health Assembly. Well, the World Health Organization responds to the needs of its member states. And those member states report through and are supported by the WHO regional offices. So if we, could follow the example, for example, of PAHO and the excellent work that you presented yesterday, and we could then work similarly, collaboratively, and engage with our respective regional offices of WHO, I think that would be one useful strategy. And then if we could go back to Mark. So we started this webinar with Mark. And Mark, if I could get back to you with your IFMBE hat on. So what Jitender said, a large part of it actually is food for health technology assessment, as to show the cost effectiveness of various interventions and strategies. So here we have the IFMBE, which straddles biomedical engineering, clinical engineering, and health technology assessment, which in a sense is ideally positioned to actually lead that synergy and to make a very powerful statement and value proposition to the WHO and to other stakeholders. And of course, IFMBE is joined to the International Organization of Medical Physicists in IUPESM. So perhaps, Mark, if I could just ask you in coming to a close, before I hand back to Pedro, what your thoughts are on how you think the IFMBE as an organization straddling these different areas that we now all agree are very important for driving this agenda forward, how the IFMBE itself could take this forward.
Yes. First of all, there is a continuous fight to be recognized as an important element in the health system. Biomedical clinical engineers and medical technicians, and also the people involved with the medical imaging. Another point I wanted to raise, which is a conclusion from the COVID period we passed, is the extreme importance of data. We have seen that there has been a need for knowing exactly where we are heading with the epidemics by hard data. And the hard data were given by the health systems and were available through institutions such as WHO and other national institutions. So I think one of the conclusions we can draw from the COVID period that is hopefully ending now is that we could provide and follow what happened via data, and very good medical data, and the access of good, very fast available medical data is been, for me, one of the conclusions of this period, and the importance of it and the successes we booked by taking good or bad decisions based on data. I think this is a very new fact in the scientific and in the medical follow-up of this epidemic, which has not been put into highlight sufficiently yet.
Thank you, Mark. Thank you. I see that, Louise, you've got your hand up. I think you mentioned the importance of data yesterday, but before I hand the floor to you, just to say that we live in an era of fake news, and we also have fake data. So I think the data needs to be tested. It needs to be verified before it becomes proper information that we can use, and information, if tested and verified and utilized, then becomes evidence. So I think there's a hierarchy of going from raw data to information to knowledge. But Louise, why don't you end with some pearls of wisdom?
Thank you, everyone, and congratulations, everyone, on great presentations. I think that this information is very important, especially what Mark was mentioning. I think that, well, actually, a Greek friend told me not so long ago, stop placing your faith on hope and start placing your faith on data. So there's a lot of assumptions going on vaccination, on medical devices, and on industry as well. And we need to start understanding on how to best use data. There's a lot of what it's called vanity metrics, which sounds very good. For example, a country holds, I don't know, millions of vaccines. That is a vanity metric. You know, there are things that sound really cool and make you feel awesome, but are not worth anything on the field. And I wanted to ask a quick question regarding innovations in digital health to the panelists, and I wish maybe a couple of people could answer. In low and middle income countries, there's a lot of innovations, there's a lot of talent. I can speak up for Mexico, for example. Last year when the COVID pandemic hit, there was a lot of groups of universities, of private companies, of entrepreneurs trying to build up technology, right? Unfortunately for them, they realized that building medical devices was not building just another machine. There's a lot of considerations, especially on health purposes, to be taken care of. But unfortunately, for digital health in countries like Mexico, there's two barriers of entry which are really, really hard, and I would like to address these points with the panelists. Number one is a big generational change where we are struggling to work with doctors that are people that are over maybe 50, 60 years old that have always used paper as their main reference and Excel spreadsheets, et cetera, to change into maybe digital health records, right? And start building data and using that data onto better purposes. And the second one is, of course, corruption and politics. There's a lot of information that doesn't want to be shown up to the light, especially related to medical devices. So my question for the panelists are, how have you in your own countries have battled with these two barriers of entry? So first, how have you made understand key stakeholders that we need to go into digital health to produce data and to start making decisions? And number two is, how do you fight corruption, which is a big, big open question, of course. But how can you make, especially government people, understand that money is a second part to health in people, and it's really unfortunate situations like countries like Mexico who struggle a lot with these problems. So back to anyone that wants to answer these maybe not so easy questions to answer, but we would love to hear from the experience that you had as a country. Thank you very much.
So thank you, Luis. I would say wait 5 minutes. And what do I mean by that? For the question of people understanding, the older doctors understanding that they need to learn these things. How did Kaiser Permanente, the 12 million person health system in the US that I worked for 25 years, deal with doctors learning the new electronic medical record? They had their kids teach them. The younger generation are digital natives. So tomorrow, wait 5 minutes, your generation and those in between, you and me, about 40 years difference there, will teach, the rising new doctor leaders are going to be digital natives. I don't think that's going to be a problem. Corruption, we've got to be very transparent, but there's, once again, my buddy Jatender has had to deal with a whole lot of that, and there's, not easy answers, but transparency is the first step. And Mladen, I know time is running short, my brother.
Yeah, so is there another panelist that would like to briefly respond to Luis before I hand back to Pedro?
Maybe one point.
Yep.
About low-level corruption at the hospital level. A very good system, electronic system that manages the hospital, just like Open Clinic, exposed a lot of corruption at the local level, where monies were not put in the central office, but were diverted to individuals, and not these were uncovered by a good electronic system in the hospital. But at a bigger level, of course, it's following the rules of that were also prominently promoted by WHO, and there is a whole guideline how to do the acquisition of equipment in a solid way. If this is followed, you can fight corruption, but it's a difficult problem.
Actually, you answered a question that a dear friend from the United States asked me. He said, if you could change one thing in Mexico to fight corruption, what would it be? And he was talking about education, culture, etc. And I told him, invest in technology. That is the framework so that you can make sure that these stuff doesn't happen. So you make clearly that point. Thank you, Mark, very much.
Please.
Yeah, Luis, I think that's a topic for another webinar because it's got many dimensions, but I think Mark has given a very practical, again, example of the value of digital health interventions at a practical level. And also I think it talks to what Riyad asked at the very beginning about the role of regulatory agencies. So if the regulatory agencies do their work, and assuming that there are effective and appropriate regulations in place, that also makes it more difficult. But as I said, that really is a topic for another webinar. So I'd like to thank you. I'll step down now and hand over to my colleague, the moderator. Yes, Rosanna?
We need to be quick, Rosanna. Time is late.
Very good to finish the session. Thank you very much. If we are able to make something, this issue is not going to be possible without regulation, a regulation framework. It against not just to bad practices, but also to make improvements regarding the corruption. Corruption is everywhere. Let's imagine in Latin America and the Caribbean, but we are not alone in this specific problem. Thank you very much for your last insight.
Yeah, well, thanks, Rosanna. I mean, you've got me thinking that, we've got the Global Clinical Engineering Journal, and I've mentioned health technology assessment. So here's an opportunity for all of us, all of you, and our colleagues to actually do a health technology case study on the impact and the consequences, both intended and unintended, of corruption, and how that impacts on access to healthcare and access to digital health interventions. So this is a call to say, we should come up with the data and the evidence, and that will be part of the driving for change. But on that note, I'd like to hand back to Pedro for his vote of thanks and to close the webinar. Pedro?
Yes, thank you, Mladen. I will thank you also for your very good work, and I also only will encourage all the people, all the colleagues, and all the faculties. Please use all the experiences you heard today and what we have at the CED, what we can share, of course, and we are also thinking how we can help each other to improve all the digital health. That is the only way how we can shorten all the gaps that we have in the low-setting countries. I think it's the best mode how clinical and biomedical engineers can put and have impact in the health sector. Very much we can also help all the people who needs. Thank you very much for all the organizers for this webinar, and also you, Mladen, for your very good work. And also Tom, thank you very much all.
Bye, everyone.
Bye. Thank you.
Bye. Have a great day here, everyone. Amazing.
Bye.
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 Congratulations.
Thank you.
Bye-bye.
For all. Thanks for the
Thank you.
invitation.
All the best.
Thank you for all.
Thank you.
Thank you for all. Thank you, Kali Roy, for your support.
Bye. Take care.